Bueno, vamos a comenzar con la segunda mesa. Después del café y después de haber estado con nuestros patrocinadores, que son Nueva Mutua Sanitaria, ATM, Sabadell, Escuela de Osteopatía de Madrid y Editorial Panamericana, la Asociación Española de Fisioterapeutas y San Rafael Nebrija. Bien, os recuerdo nuevamente que estamos con el hashtag RCMAT17, que podéis seguir tuiteando. En la actualidad, ahora mismo tenemos 1.885.000 impresiones, 829 tweets. Y así que nada, pues vamos a seguir hablando de fisioterapia y para ello pues vamos a empezar con la mesa número 2, que os voy a presentar al moderador, que ya le conocéis, Pablo García. Así que, Pablo, cuando quieras.
Bueno, continuamos. Continuamos con esta segunda mesa. Es un placer para mí coordinar, pues esta mesa titulada Enfoques del proceso de razonamiento clínico. Tenemos la suerte de tener a tres de las mejores personas que yo conozco que pueden acercarnos a este concepto, ¿no? En primer lugar, vamos a escuchar la ponencia de Mark Yeung. Como ya sabéis, Mark Yeung viene de Australia, él es fisioterapeuta, de acuerdo, lleva allí en Australia ya muchísimos años. Él estudió terapia manual con Geoff Maitland. Después de graduarse en terapia manual con Geoff Maitland, él estuvo trabajando allí con él y publicando con él una serie de artículos. Y bueno, ha intentado expandir el método Maitland y ha intentado llevarlo a una de las áreas que vamos a ver aquí ahora, los factores psicosociales, el razonamiento clínico, el conocimiento del dolor, ¿de acuerdo? Es autor de muchísimos artículos y también de varios libros. Dentro de muy poquito vamos a tener una nueva edición de su libro de razonamiento clínico para la terapia manual. Por lo cual, empezamos ya. ¿De acuerdo?
Hola. I want to thank the organizers for inviting me to speak at this conference. I'm very honored to be here amongst my other keynote presenters. And I want to congratulate the speakers this morning. I found it incredibly interesting and really well informed. So I think it looks like this conference as a whole is going to be excellent for everybody. The diagram I have on my title slide highlights the patient in the middle with the biomedical or biological pole off to one side and the lived experienced or psychosocial pole off to the other. And they're both incredibly important, and oftentimes I would speak about the whole spectrum of clinical reasoning, from reasoning about the biological pathology, physical impairments, clinical diagnosis, as well as the psychosocial. But for this presentation, I've chosen to focus primarily on psychosocial. So I'm going to talk about psychosocial factors and their importance to understanding and managing patients, and about physiotherapy assessment and clinical reasoning of psychosocial factors. So I want you just to think, as I talk about this, what psychosocial means to you, because it means different things to different people. How do you assess a patient's psychosocial status? Do you use questionnaires? If so, which questionnaires do you use? Do you use questions in your patient interview to understand their psychosocial status? What questions do you use? Do you have categories of questions? When do you assess psychosocial? Do you do it on the first appointment, or is it something that you go into later? If you identify potential psychosocial factors, how do you judge when they're relevant or not? So what's your clinical reasoning about the significance of a psychosocial factor? which I would argue is a little more difficult than physical impairment. You can tell me my shoulder range is restricted because you have normative data about what to expect, but psychosocial factors are more challenging to judge their relevance. And then the last thing to think about as I'm talking is, when do you refer patients on to other health professionals when you think the psychosocial factors are outside your scope of practice, and who do you refer them to? So hopefully I'll cover these sorts of issues as I talk through this. Now this is a very well-known diagram from the World Health Organization, their Icf Framework, which is really a biopsychosocial framework. And it really nicely highlights the contributions to a patient's pain and disability, coming from the health condition, what we often think of as the pathology or the disease that underlines their problem, but also on the boxes at the bottom, the environmental factors, the personal factors, the psychosocial influences. So our reasoning, to be comprehensive, has to consider all of those factors to understand a person and their problems. So biopsychosocial practice. Well, physios are well educated to be able to assess and manage physical aspects of their patients' problems, what I refer to as physical impairments. But research, including some nice systematic reviews on physiotherapy biopsychosocial practice, highlights a range of problems related to psychosocial. And that is that physios have been shown to only partially recognize negative psychosocial factors. They're not thorough in their recognition of this. They tend to pay less attention to the social factors, more attention to the psychological factors. Physios tend to prefer dealing with the mechanical, physical aspects of patients' problems. Some physios have been demonstrated to stigmatize patients who present with apparent negative psychosocial factors. And generally, physios don't feel their undergraduate training or their professional development courses have equipped them to be able to assess, reason, and manage through psychosocial factors. So I feel this is an area that is really important for our profession to develop further in terms of what do we assess, how do we reason through it, and then of course, what can we do as physiotherapists to manage this dimension of patients' problems. Now, there is overwhelming evidence about the importance and the value of a biopsychosocial approach to practice. But despite that, you'll come across many physios who don't feel comfortable with psychosocial assessment. They, for example, feel that they're not a psychologist, they're a physiotherapist, so it's not my role. So that's one opinion you come across. You also have physios who tend to think psychosocial is only relevant to chronic or persistent pain. They don't think about it in an acute pain presentation. Then you have some physios who claim to be biopsychosocial. They say, yes, that's really important, that's how I practice. But if you watch them in practice, that's not how they practice. And I get a chance to see that because I work with postgraduate physios who are coming back and tell me they're biopsychosocial, but when I look at them in practice, they're not. They're very, very biomedically focused in their approach. And they tend to have what I call a dualistic conception of biopsychosocial, that it's either psychosocial or it's physical biological, when in fact, in reality, there's always an interaction in every single patient. And it's an interaction of mind-body that is there and needs to be understood. And then there are those who I would say are biopsychosocial in their philosophy of practice, and they're doing the best they can, but they haven't had sufficient training so that their assessment is superficial and it's not very structured. It's not as organized as their physical assessment. Okay, so there is overwhelming evidence about the relevance of psychosocial factors to patients' pain and disability problems, so that their thoughts, their feelings, their self-efficacy, their coping strategies contribute to their pain and disability. And importantly, they contribute not only in a negative way, but they contribute positively. For some reason, psychosocial's been attached or has been associated with a negative construct. You have negative psychological factors or negative beliefs or negative social circumstances. In fact, it's often very positive. And it's why some patients with very significant health problems cope very well or do well with their problems because they have positive psychosocial factors in their presentation. So what do we know about factors, psychological factors? Well, I've listed here broadly the things that the research is supporting. And that is that maladaptive or unhelpful thoughts, beliefs, emotions can adversely affect a whole range of things. They can affect the sensitivity to mechanical and non-mechanical stimuli, pain intensity, pain tolerance, function. Behaviors related to pain are affected by thoughts and beliefs, so avoidance, catastrophizing, overactivity, and behaviors related to care seeking, such as looking for passive solutions to their problems. It can adversely affect a person's self-concept, what they feel about themselves as a person, and their self-efficacy, what they feel they can do and contribute toward their own management. It can adversely affect their relationships, the relationships at work, relationships at home, their quality of life, and their ability and willingness to participate in physiotherapy. So this whole area is really important to patient outcomes. There's a body of literature referred to as stress and coping theory, and it tells us that patients' pain, especially persistent chronic pain, is a source of stress to most patients. And whether and how stressful it is very closely associated with the patient's cognitive appraisal. That is the meaning that their problem, their pain, their diagnosis, their pathology has to them. So you'll see under cognitive appraisal there, it can either be conscious or precognitive, unconscious. So people aren't even always aware of what they think because they've never been questioned about it. And it really comes down to their concept of whether their problem, their pain, their health problem, is a benign thing that is not really going to affect their future, such as an ankle sprain where you're not really worried about it, or is it something they feel threatening and whether they feel it can be helped, whether it can be managed through physiotherapy or other medical management. So that's the cognitive appraisal that every patient goes through when they have a health problem. Then, understandably, we all have our own ways of coping with problems, including health problems and pain and disability. And so a person's coping is their individual strategies that they've consciously or unconsciously adopted to be able to master, tolerate, manage, maybe resolve their health problem. And these are the things that I suggest we need to understand about our patients. So through our assessment, we need to understand their cognitive appraisal, we need to understand their coping strategies, and of course coping strategies have effects. Are they effective for the patient? And we need to simply ask that question. And the outcomes of their coping strategies will lead to reappraisal, reconsideration about the threat their problem exists. Okay, so in this slide, I've just given you some examples of different behavioral and cognitive strategies. So common behavioral ones would be guarded movement, resting, relying on others to do things for you, pacing what you do, goal setting can be a constructive strategy, and seeking social support. They're common things that everyone does. Where cognitive strategies within the person's head are things like avoidance, catastrophizing, that is overly focusing on negative aspects of their health problem, distraction, pleasant imagery as a constructive strategy, coping self-statements that can be taught to patients, and reinterpreting pain. That falls into the category of pain education or neuroscience education. There's an American psychologist, Frank Keefe, who has done a lot of work in the area of chronic pain and training patients in what he calls active coping strategies as opposed to passive coping. And this is a slide that I borrowed from Frank that highlights some of the common things that people do. So on the left-hand side, you have patients who are taking medications or drinking alcohol in the middle, or smoking, or overeating are very common behavioral coping strategies for all sorts of health problems, including pain and musculoskeletal problems. And what he highlights in this next slide is that in the short term, these can be quite effective. So you might call them adaptive strategies. They reduce pain and they can reduce negative emotions. So it's not surprising that a patient who might try some of these strategies would then continue with them, because in the early days they help. They reduce pain, they make them feel better. But unfortunately, as I'm sure you already know, in the long term they're ineffective. And this is the problem with passive coping strategies that patients have. So they lead to remodeling and neuromodulation in the central nervous system that can lead to more response to the stressors, increased sensitization to different stimuli, dependence on alcohol, smoking-related diseases, drug addiction, obesity, and then across the bottom, they all ultimately lead to increased pain. So as therapists, we need to understand the ineffectiveness of these examples, and they're the sort of things that we would incorporate into our education when we're working with patients about this. Okay, emotions are also, they fall into the psychosocial realm, so it's not just what a person thinks and believes, it's what they feel that we need to understand and attend to. And we're talking about emotions such as anxiety, stress, frustration, anger, fear, self-worth, and legitimate clinical depression. And we see that in our patients, particularly those with persistent pain. And just as an example, how relevant these are, levels of anxiety have been shown to be correlated with severity of pain, higher complications following surgery, longer days of hospitalization. And interestingly, the anxiety is most common when the symptoms can't be explained, which is often the case with persistent pain. You get conflicting explanations to your problem. And there's concern about the future, what it holds to me. And there's worry about what other people think about me. All of those things enhance anxiety. And there's a reciprocal relationship between the thinking itself, the cognitive appraisal, and negative emotions that then further increase this threat appraisal when you have those negative emotions. On the other hand, research demonstrates that if we can reduce pain-related anxiety, and I would say through education and physiotherapy, cognitive behavioral strategies, then we can not only improve functioning, distress, pain, but also activity levels. So there's quite a body of evidence that supports the rationale for this and the efficacy of it. So efficacy, that here I'm referring to a patient's belief in their ability to do something for themselves, whether they feel they can make a difference or they're coming to you as a physiotherapist to fix their problem. Patients with low self-efficacy, and this can be assessed, there's questionnaires that will measure this, quantify it, but when you have low self-efficacy, you tend to have beliefs that your efforts won't be successful. You need other people to fix your problem for you. You tend to use less constructive coping strategies. You rely more on the passive ones. And perceived helplessness, that there's nothing you can do, is related to pain and disability. So it's an important area for us to assess and then monitor as we do our different interventions. So what's the basis? So on one hand, we're going to say the psychological aspects of psychosocial relates to a patient's beliefs, thoughts, feelings. But where do patients develop their beliefs and feelings from? It's maybe not so hard to recognize them, but where do they come from in the first place? And are they the same across different patients? And I would say they're not the same. People are individual. They'll have their own unique beliefs. But there are some common features like clinical patterns. And clinical patterns in diagnostic physiotherapy are useful to know, but there's many variations of clinical patterns that you also have to be alert to. So there's some really interesting research. It's given the name self-regulation model by a man named Leventhal. And it goes back to the early 80s, but it's still really well recognized as very sound research that I think helps highlight what we want to learn from our patients, what we want to assess. So he talks about a person's individual beliefs, and I like to call them a patient's perspectives, about their health problem, their diagnosis, their pathology, their pain. And these are learned either from explanations, what your physio told you, your doctor told you, what you read on the internet, so some of it is what people have told you, but it's also learned from your own experiences when you've had a health problem before, or you've watched somebody in your family have a health problem. So you learn it both explicitly from what somebody tells you and implicitly through conditioning, through association. And what Leventhal demonstrated that is common across all patients is that they have a name for their health problem. So for example, I could go out on the street and interview 100 people and ask them about a cold versus pneumonia. And they would all have beliefs about cold versus pneumonia if they've heard of them, or back pain versus disc prolapse. And this is what their beliefs include. It's the name, it's beliefs about how long they expect the problem to last. A cold might last a few weeks. Pneumonia, I've never had it, but I think it lasts a lot longer. Beliefs about what caused the problem, and this often is very individual, so it's what your mother or your grandmother told you, how you get a cold, or how you get back pain, or how you get a disc prolapse. Beliefs about the likely effects of the health condition. What are the consequences of the health condition? Is it a benign thing, or is it something that's more threatening? And beliefs about prognosis, and this is a big one. Their beliefs, is it controllable, curable, can it be helped? And this is often where they have beliefs, but their beliefs are not always accurate. And this is important for us to assess, because if we judge they have misconceptions, then we call it an asterisk. We target that as something that we're going to address in our management through education, but also through physical interventions such as pacing, etc. Okay, so I want to now just come back to the idea of cognitive appraisal and threat assessment. And there's a lot of theory now about pain being an output of the brain and has a strong association with whether the event is judged to be threatening or not, is whether nociception will actually be experienced as pain or not. But what Leventhal and his other group of researchers also demonstrated are what are the common features that people determine how threatening something is. And this isn't just about pain. This could be about any health problem. And they're pretty self-explanatory or logical. So how serious do you think your problem is? I don't think a cold's very serious. That's not threatening. I don't think an ankle sprain's very serious. But back pain, yeah, I know somebody who had to have surgery, so that raises the threat level to me. The extent that your life is affected, are you able to keep working? Can you still do things at home? The more it's affected, the greater the threat level. The social desirability, and this is an interesting one because I don't think people always recognize the social consequences of health. And for example, if you have back pain in the workplace, there's often a stigma. Do you really have a problem? Are you carrying your load? You can't see anything, you're not bleeding, and research of chronic back pain shows that people will acknowledge, I do limp, I do adopt these behaviors, so people will believe I really have something. So there's a social aspect to it. And in the area of women in chronic pelvic pain, there's all sorts of relationship issues that are linked to feelings of guilt and shame, which is a very social and emotional aspect that raises the threat of their health problem. And then the last one is, do you think it can be helped? Is your problem controllable or changeable? And remember, as you're looking at these are what I'm suggesting we should assess. These are the things that we know exist, and so we need to assess these in our patients. So patients' perspectives, these illness representations, using Leventhal's language, or their beliefs. So what you believe can then influence your pain through neuromodulation. It can influence your coping behaviors. What you do for it is based on what you think you should do for it from your illness representation. Your expectations for treatment, if you believe pain equals damage, you don't want anything that's going to cause you pain, because in your thinking, that's only going to further worsen your condition. Your willingness to take responsibility and self-manage is influenced by your perspectives, your self-efficacy, what you think the future holds for you, and your goals. So they're very significant as far as their impact. But it's never black and white, and I think it's the same with physical health and physical impairment. You can have a real minor impairment, a little bit of stiffness and a little bit of pain, and you can have somebody who can't lift their arm at all. Well, psychosocial factors are the same. There's a continuum. So people can be at the lower end and have minor stressors in their life, and I've given an example here. So there's selective attention to sensory information, so they are focusing on that painful area. They have low levels of fear of movement because they don't want it to make it worse. Frustration because they can't play their sport or they can't do some things at home. But it's all at a relatively low level. And at the lower level, many patients just adjust over time. As the biological health problem recovers, these things go away. Or they respond very well to physiotherapy education and activities to reactivate them, exercise and pacing activities. So we're really well equipped, probably the best profession to deal with these at the lower end and a little bit into the continuum. But I want to highlight at the far end of psychosocial distress, and here you have greater pain and disability, greater stress, distress, catastrophizing cognitions, hypervigilance, where you're over-focusing on every body sensation. Everything you feel, you interpret as being another problem. Broader fear avoidance, and so you've really reduced everything. You're not working, you're not exercising, you're not socializing. With these, you have greater negative emotions. Your emotions get intermixed with how you feel about yourself, so your self-concept, your self-worth goes down. You're not a good mate, you're not a good partner at home, you're not a good parent because you can't do the things that you used to be able to do. There's hopelessness, helplessness, and actual clinical depression. And I think it's important for us to recognize when psychosocial factors are outside our scope of practice, when they're bigger than what we can deal with because of our training and also the time that we have. So I'm going to argue that with education in psychosocial assessment and management, we can address these factors at the lower end of the continuum, but at the higher ends, for example, true clinical depression, or if a patient has coexisting stressors such as a relationship breakdown, it's not our role to be a marriage counselor, so we need to recognize the other comorbidities, so to speak, and we need to know who to refer to ask for assistance. And it's important, if we do refer on to a psychologist or a counselor, that we don't just get rid of the patient, we actually hopefully co-manage the patient, because we're still the best profession to explain pain, and we're the best profession to explain exercise and activity, better than the psychologist. So they will have their role, but we'll have ours, and the best management is co-management between physiotherapists and these other health professionals. Okay, so let's move on to social factors, and what are they? So what do we think of when we say social factors, and what effects do they have? Well, here's a list of the range of things. So the socio-economic factors, the social living circumstances, education, employment, relationships at home, relationships at work, compensation, health education, culture, the workplace health policy, do they have restricted duties, for example? So these are the sort of factors that we should assess. And a lot of these you can assess in a simple intake questionnaire. So it doesn't mean you have to stop and question every one of these, but we do need to know about these. And what's the influence? And what we know is that social factors, this is from the research, will influence the care-seeking options, the patient's thoughts or cognitions, their behaviors, and ultimately their health. And it's really interesting, not so much in musculoskeletal physio, but in across the health spectrum, there's enormous evidence, for example, in cardiac disease, about how significant social support is to health outcomes. And it leads to better coping, better management of the health problem, and better management of the stress. And it's important that the person has genuine support, but also perceives support. So in other words, what a patient might tell us is, my employer doesn't believe me, and he doesn't support me at all, and he won't give me any time off work. And that's perceived support, which doesn't always match reality. So we also need to look a little further about what real support is there. And what can we do? Well, for starters, we can assess it, because if you don't assess it, you don't know it, and you can't address it in the management. And we can look for positive and negative. Oftentimes, it's something we can do is help the patient see the positive support mechanisms that are available to them that they haven't really recognized or taken use of. We can discuss that within our pain education about another factor that's contributing to their pain and disability. Help them recognize what they have available, try to incorporate support networks into our management, and then we can be an advocate to the employer and contact employers about the patient's health problem, the need for restricted duties, etc. Okay, and what I want to then move on to now is more formally, how do we assess all of this? So I've really highlighted all the things that I think are important, and how can we assess it? Well, I think there's two things we can do. We can use our interview, and we can use questionnaires. Personally, I think the interview is the most important part of it, and you need to have an interview which enables you to evaluate each of the things I've been talking about. But then you can also use questionnaires, and there's broadly two categories. There's what they call multidimensional questionnaires, which assess overall psychological distress, and there's unidimensional questionnaires, which assess very specific psychological constructs, like anxiety, fear of movement, catastrophization. So you have to think about which questionnaire for which patients. The key in all of this assessment, interview and questionnaire, is what is the meaning that the patient's pain and disability has to them. This is the cognitive appraisal, and that's what I want to know. I want to know their illness representation. What does it actually mean to them? So that's what I'm questioning about. To be able to optimize patient learning, because remember, the patient may not even really be able to express it very well if they haven't thought about it, I need to be able to unpack their beliefs, question about their beliefs and their feelings, including understanding why they think that way. And I like to describe it as like a novel with a story, and there's a plot to the novel. And I'm trying to understand the plot to the novel in my questioning. So not just what do they think, what do they believe, but why do they think that way? Because my management is going to target the why. I'm not just going to say, you're wrong, you should think this way. That won't be effective. I need to know more about it. Okay, so what I'm going to do now is highlight the areas of assessment. So if you were going to categorize for your subjective interview areas to question patients on, and here I'm trying to understand the patient as a person, not just their physical problem. I think you need to understand their pain and disability experiences. That includes their activity and participation restrictions, which you would get in questions about aggravating factors, what they can do, what they can't do. The impact it has on relationships, at work, at home, social relationships. The cognitive factors. So I would never have a patient that I didn't ask, so what's your understanding of what's going on? And usually they'll say, well, the doctor said, yeah, but what do you think? Tell me what you really think is going on. And then when they tell me, I want to know, but what does that mean to you? Because when they say, I've got an L4-5 disc bulge, that just says what they understand. It doesn't tell me what it means. So the meaning could be, well, I don't know, it just means I'm getting old and hopefully you can show me what to do. Or it may be, it's terrible. If this gets worse, I'll need surgery and I'll never walk again. That's meaning. So I need to take my questioning further to understand that. to understand their threat appraisal, like I mentioned earlier, seriousness, impact, social effects, changeability. If it doesn't come out spontaneously, and it often does, and you often just have to listen for it, if it doesn't come out, then I would ask it. And their motivation for change, because that's a significant barrier for some patients. Their emotions. So I'm listening for their emotions. When they tell me they're really angry at their boss or frustrated because they can't play sport, I want to know about that, and I want to know the relationship between that and their symptoms. And I want to know the history of it. Just like we get history of different symptoms, I want to get history of thoughts and feelings. I want to know their behaviors. I want to know when they tell me they have a problem, so what do you do for it? Do you have any strategies that you've used to help you cope with it? What strategies do you use? How effective are they for you? So I'm going to explicitly ask about those. I'm going to listen for catastrophizing and hypervigilance. I'm going to question about social factors that I've listed before. And I'm going to use questionnaires, but I'm going to use them selectively. So I'm going to use questionnaires. I'm going to start with an interview, and depending on my interview, if the patient isn't comfortable opening up to some of these questions, sometimes questionnaires are very good to open the door to psychosocial factors, and I'll use them that way. Or if I get hints to something, I might use a questionnaire to explore it further. A couple questionnaires are diagnostic, questionnaires like the neuropathic pain questionnaire or the central sensitization inventory. They have some ability to categorize pain type, but really most of the psychosocial oriented questionnaires are about trying to understand patients' perspectives, their beliefs, their feelings, their coping, etc. They're not just for chronic pain patients, they're relevant to all patients, because all patients have the potential to have adverse psychosocial factors working against them. But the problem with questionnaires is they don't tell you why the person ticked the box or why they drew the line here instead of here. So 3 patients can tick the same box for totally different reasons. So we need to use the questionnaire, sure, add up the score, that's a bit of an outcome measure, but we need to use it as a way of exploring more the patient's psychosocial factors. Okay, briefly, 2 multidimensional questionnaires. One's the start back screening questionnaire for low back pain. The other one's the Orebro that I'm sure you're familiar with. There's quite mixed literature on the value of these questionnaires. So for example, they're poor at predicting persistent pain. They're acceptable for predicting disability. They're very good, especially the Orebro, at predicting return to work. But recent research, and some research out of our university, says they're really not very supportive for guiding management. So some of the stratification that was done with the StartBack tool is now really being debated. But anyway, they're there for us to use. And then I've got 2 slides that come from an excellent paper in the Manual Therapy Journal, the Belgian group. And what they've done is they've just highlighted questionnaires that are very good, and these are unidimensional questionnaires, that are very good for different psychological constructs. So for example, if your patient in the interview expresses fear of activity, you might use the TAMPA. If they express anxiety, you might use the state trait anxiety inventory. And you can look at these other questionnaires. I won't go through each of them, and I'm really just trying to highlight these are tools that we have available to take what we learned in the interview and explore it further. So there's a pain catastrophizing. One that I really like is called the Brief Illness Perception Questionnaire, which is a really nice short questionnaire about patients' perspectives, their expectations, what they think is causing their problem. And I find that really useful to open the discussions. Okay, but I don't just have them complete the questionnaire and stick it in the file with a number. I review the questionnaire with the patient. So we go back over it, and I say, tell me more about this, because I want to know why they ticked that box. What's the reason behind it? Because I'm going to have to make a clinical judgment. I don't rely on the cutoff score to categorize the patient as being maladaptive. I want to find things that I can address in my education. So I'll explore that through further interview on the second or the third appointment as they come back with completed questionnaires. And when I'm finding this information, I also cross-check the relationship with the history and the symptoms. Because you can have adverse psychosocial factors that have been there for years, way before this problem started. And maybe they haven't changed since this problem started, or maybe they have. So I want to try to understand the association between those. And that leads me to this factor, because I don't want us to be thinking that psychosocial is negatively part of every chronic pain presentation. So the first one says yes, it can be, especially in chronic pain, it can be a dominant factor that is contributing to maintaining pain and disability, and it has to be addressed in management. That's true. It can be present, but not a barrier. So in other words, people can have it, but they're coping with it because they've got a supportive employer, a supportive family. So they're coping all right, even though they have some adverse factors. It can be present and contributing alongside nociceptive factors, physical health factors. So it's not either or, all psychological or all physical. There's mixed, there's different presentations, and that makes it hard for us. Which one is dominant? Which one do I address in my management, or do I address first? And they can be present and a risk factor for chronicity. So even in an acute pain state, if I identified really significant beliefs and psychosocial factors, I may change my management. I may not use hands-on therapy. I may deliberately use a more active hands-off approach because of risk factors that I identified. Now, this whole area of psychosocial factors has a science behind it, and there is a neuroscience of your thoughts, your beliefs, your emotions, and pain. We know there's a neuroscience of pain, but there's also a neuroscience of beliefs and emotions. They are, using Melzak's terminology, they're neurosignatures, or some people call them neurotags, of the neuroimmune network. And they're modulated, these brain pathways are modulated by sensory inputs, nociception through the body, but they're also modulated by beliefs, stress, expectations, and emotions. So they're really important to addressing pain and disability through a neuroscience approach. And I like to think about a patient's subjective conscious experience as their virtual reality. It's what they believe to be true. And it's like a chronic pain is trapped in their own virtual reality and their own perceptions of what pain means to them, what other people think about them, whether they'll ever get better. Because that's what I'm going to try to change, if I can, and help them reconceptualize to adopt a new reality. How do I do it? Well, pain neuroscience education or pain education, there's different terms for this. It's about changing, reconstructing beliefs collaboratively, not lecturing our patients, and it can reduce hypersensitivity. It can reduce this sensitization, and helping them understand that their pain in this extreme case is not just due to tissue damage anymore. It's due to these other factors that we've been talking about in my education with the patient. There's practice guidelines. The work of Joe Nice out of Belgium is excellent if you haven't looked into this area. There's really good textbooks now. I'm sure everybody would know of the books now, and the new book by Mosley and Butler, but also Adrian Lowe is an American from South Africa that's got a really nice new book on pain neuroscience education. And the evidence is supported. So there's systematic reviews supporting the efficacy of pain education, pain neuroscience education. It has positive effects on pain, disability, catastrophizing, and physical performance. And the optimal effects are achieved when the education is combined with exercise, motor control, pacing, reactivation, which is what Joe Nice calls cognition targeted. So it's exercise that is continually reinforcing the pain education through the exercise. So it's not a lecture first and then a bunch of cognitive behavioral therapy. It's the education all the way through the management, because beliefs are hard to change. So physios should be able to address and manage patients through education and cognitive behavioral strategies and promote reactivation. At the higher end of the continuum, I think we need to recognize when we're out of our scope of practice, we need to know who to refer to, we need to develop the relationships. You should be able to get onto a phone with a psychologist and talk about a patient, just like you can call up a GP or a surgeon. You need to have that same sort of network. And then you need to discuss that with the patient when it comes to that point where you're not going to stop seeing them, but because of some of the factors they've talked to you about, that person needs additional assistance that you're not trained to give. Okay, my last slide then is that you don't have to be a psychologist to assess, reason, and manage psychosocial factors. You do have to have a holistic view of health and disability, so it has to be not just biological, but biopsychosocial. You need to have skilled diagnostic, physical assessment and reasoning that I haven't talked about, but that's equally important, because you can't understand the whole person just by assessing one, but also psychosocial assessment and reasoning has to be really well developed. I think it requires pain neuroscience education skills that we have to upskill ourselves in, cognitive behavioral therapy skills like active coping skills training, and knowing who to refer to when you need assistance. Thank you.
Por su clase magistral. A continuación les presento a Yeung. Yeung viene de Canadá, viene de la Universidad de Toronto, él es fisioterapeuta. Él es doctor desde hace muy poquito, él ha realizado una tesis en razonamiento clínico, ha desarrollado una rúbrica para la evaluación de esta competencia dentro de la terapia manual, ¿vale? Y lleva pues aproximadamente unos 20 años trabajando en esta universidad con sus alumnos y con sus compañeros intentando sacar el máximo de ella, ¿de acuerdo? Su ponencia lleva el título de razonamiento clínico relacionado a la materia con el contexto, ¿de acuerdo? Cuando tú quieras.
Thank you for the introduction, Pablo. So if you don't mind, I'm just going to take a picture for my wife. If you can just raise your hand, wave, please. Thank you. Thank you. I'm hoping that picture will make up for the fact that I've left her for 4 days with my 2 young kids. So thank you for the introduction again, and good afternoon. I appreciate your attention, and thank you for inviting me and for organizing this wonderful conference. So my name is Yeung. I come from Toronto, Canada, and I just got in yesterday, so forgive me if I'm still a bit jet lagged. As you can see in the picture here, we just finished a season of wonderful color changes in our trees, and we're heading to good at least 4 months of winter, 4 or 5 months of winter, and a little bit of snow. So we're changing colors to white. So thank you, Pablo, for that picture of the snow and the trees. It's to come, not yet, but it's to come. So I live in Toronto, and here's a picture of our wonderful city, and this is close to where I work. I work at the University of Toronto, not too far from the CN Tower that you see in the background there. The campus is right in the foreground there. And I also want to thank you before I go on the presentations that preceded me for this morning, and also Mark. They really set it up nicely for what I'm going to be talking about in terms of context. So now I've been teaching at the University of Toronto the Entry to Practice program in physiotherapy in orthopedics for probably about 15 years now, and I also teach in the postgraduate, so a post-licensure manual therapy diploma program for about the same number of years as well. Both of these programs value the teaching of clinical reasoning a lot, so I feel that I've been living, talking, breathing clinical reasoning and physiotherapy for many years. First as a clinician, I practiced for almost over 20 years as an orthopedic therapist, and then now more as an academic at U of T. So I've always been fascinated with clinical reasoning and how complex it is, particularly in my own clinical reasoning, again as a clinician first, and noticing the different ways that it's complex. So from day to day, from patient to patient, how my own thinking process is different, is distinct, and in some ways very complex, even with patients with the same diagnosis. So my fascination with clinical reasoning stemmed from my work, and it brought me to do a doctorate in education in the area of reasoning and how to assess clinical reasoning in particular context. So a big part of my work at U of T and also in the diploma program is to evaluate and teach clinical reasoning. So what I do at U of T and what I do in the diploma program mirrors each other, just different spectrums, so very novice learners and then more experienced learners. And what I keep coming up against is the issue of how to prepare physios and how to prepare physio students to think through a clinical problem in an efficient way, an effective way, so that they can do the same not only in the classroom, but more importantly in the clinical setting that they will be in eventually. And that's definitely not an easy task. So to illustrate one of the greatest challenges that I have observed over the years, I'm going to introduce you to a physiotherapy student whom we'll call Peter, who was by all accounts a good student. He put in a great deal of effort in studying, and that resulted in above average grades. So his tests, his exams, above average grades. And in one of his final clinical internships, he started out doing very well and was able to describe verbally his plan of attack for assessing and treating patients. But as the internship progressed, Peter's clinical supervisor found that his clinical reasoning wasn't as consistent. So for example, he would assess a patient with osteoarthritis of the knee. He would carry out a reasonable assessment and treatment plan on that patient. But for the next patient, also with osteoarthritis of the knee, Peter didn't seem to have the same level of clinical reasoning. He couldn't demonstrate the same kind of clinical reasoning on the next patient. So for example, Peter's clinical supervisor noticed that Peter couldn't really change on the fly. So for example, he seemed to struggle most when the patient's response wasn't as he intended or as expected, or that he didn't anticipate a certain response. So when this happened, you could tell Peter was confused or that he was struggling with his clinical reasoning. He would be almost randomly selecting different tests or questions to ask the patient. The tests he would select were not so relevant and didn't really pertain to the task at hand, almost as a way to try and mitigate the uncertainty. So I don't know if you can relate to that, maybe as a learner yourself, or you've observed that in a colleague, a student, a more novice physiotherapist. Unfortunately, Peter failed that clinical internship, and I was asked to provide some remedial help to him. And this was his last clinical internship before he was graduate. So there was lots at stake. So we'll talk more about that later. So I'm just going to take a moment to ask you, what do you think was going on with Peter? What do you think was going on with his clinical reasoning? He received excellent grades, as I said, on his tests. He demonstrated good clinical reasoning with some patients, but he couldn't do the same. He couldn't reproduce the same level of clinical reasoning with patients, even with the same diagnosis. What was going on here? So now there could be many, many reasons for that, but for the purpose of today's talk, I'm going to really get you to focus in on clinical reasoning in particular. So to be fair to Peter, let's have a look at what might be at play. So maybe the cases that he was given were too hard for him. There were rare cases. So let's have a look at one of these cases that Peter was met with. Okay, Peter's case here was this patient was Mr. M. He's a 45-year-old with posterior knee pain. And the patient comes in and tells Peter, I believe I have patellofemoral pain syndrome, and he's asking for advice on exercises to help him return to recreational running. So I want to just take a few seconds to think about that and talk to the person beside you. What do you think is going on? Given this information, take a few seconds to talk about why do you think Peter's clinical reasoning was the way it was? So just a few seconds and report back. So, just for the interest of time, I'll go on. So for me, some possible explanations were that perhaps he had inadequate knowledge about what posterior knee pain could represent, what patellofemoral pain syndrome was, how to assess the knee comprehensively, and generally faulty clinical reasoning processing, perhaps. Now, all of these that I started thinking about first had to do with Peter's knowledge and his cognitive processing. And we know that cognitive processing is really important. We know that for sure. We know that from years of research. That's not new. So we know that experts, for example, have more elaborate knowledge representations. The conceptualization of disease, illness is more elaborate. So maybe, perhaps, Peter just had insufficient elaborate knowledge. We also know that experts also have efficient ways, effective ways to organize their knowledge. And so, perhaps, Peter just didn't have was inefficient at processing information. So it's entirely possible. Okay, the traditional way of thinking about expertise development in reasoning. But we have our tests in our programs to evaluate these things, and he scored well. Could there be something else? So, I'm going to give you a bit more information. So on the left here is information I already told you about Peter. On the right here is some additional information that I'm going to tell you about the patient and more about Peter. So the first thing is Mr. M has a mistrust of physiotherapy students because of prior experience. Second thing is Peter has not had any previous work experience in a privately funded setting in which he's having this clinical internship. And this is also his first internship in a very busy orthopedic clinic in which he's expected to see 2 patients at once at any given time. So you'll notice that this additional information has very little or nothing to do with Peter's knowledge or cognition, but nonetheless are very important for us to consider. So if this were you, this would probably affect your clinical reasoning. You'd have to manage the patient's mistrust. You'd have to manage the implications of working in a privately run clinic. You'd have to manage the expectations of having to see 2 patients at once. So no wonder we saw some variations, perhaps, in Peter's clinical reasoning from case to case. So the term context specificity has been used to help explain some of these things that we're seeing here, this phenomenon, where we are observing variation in a person's clinical reasoning performance from one case to the next. So again, this is not new. This has been substantiated by years of research, and they found that even with the same diagnosis, even when the diagnosis is the same, there's low correlation with clinical reasoning scores or performance across particularly novices, but also in experts. Let me be more specific about some of these factors that we're talking about. So now when I say the word context, many of us probably think of the physical environment, the physical setting that the encounter is taking place in. And while that is really important, for sure that's important, the context extends beyond the physical setting, as we can see in Peter's case. So I think we need to acknowledge some of these other factors that don't get talked about a lot, or maybe at all. Here's one researcher. This is a model by Durning in 2010. This is his take of a host of factors, and I would add to that list. As we talk, I'll add to this list to elaborate on what context means. So you can see here that the context contains the patient itself, or himself or herself, the therapist, and also the actual encounter, the things that happen during the encounter with the patient. So in Peter's case, it was important for us to consider all of these in his remediation. So let's see what the research says about the contextual factors. So first I'm going to talk about the encounter factors. So researchers have noticed that outside of the individual practitioner's cognition, the actual encounter is critical to clinical reasoning. So for example, the lack of time has been found in the clinical encounter to compromise clinical reasoning performance. So they did this, a study was run with physicians who are internists and physician trainees, and they found that their clinical reasoning scores were much lower when they were introduced to things like time, lack of time. So again, that's probably not a surprise to you. It's fairly obvious if you have less time to reason, your reasoning process probably will be less strong, less elaborate, less extensive. Well, I think what was most interesting about these studies is that they were able to manipulate these contextual factors even with experts. So expert physicians kept missing key pieces of information, which then compromised their ability to clinically reason through cases. Now, these two studies by Durning that I listed here, they show us something quite important. So they brought internists in, the trainees in, and they ran them through a whole series of videos. They have them watch them. They introduced different combinations of contextual factors, such as lack of time, such as incorrect suggestion of a diagnosis by the patient, or incorrect suggestion of a treatment by the patient. And both, as I said, both these groups miss key pieces of information. Whereas the experts, so the trained physicians, they were able to look back at the videos and say, this is where I went wrong, this is how I might manage the contextual factors. The trainees themselves could not do that. So like in Peter's case, they floundered even more. So even when they went back to the videos, they weren't able to pick up what the contextual factors were and how they influence or compromise the clinical reasoning. So I think what is new here is the physical setting is one thing, but I think the encounter, the actual factors around the interaction with the patient is even more important. Let's talk about the patient factors for a second. So the same researchers also teased out a bunch of patient factors that seem to interfere with clinical reasoning. And it's, again, no surprise that if the case is more complex, and I'm not just talking about the physical impairments, complexity could also pertain to the psychosocial issues that Mark talked about. That seemed to also interfere with clinical reasoning. They found that the patient's language proficiency, they specifically introduced that contextual factor as a way to complicate matters, and that was one of the greatest impacts on clinical reasoning. Again, some of these are apparent in Peter's case. So let's go back to this diagram for a second. So some of you are probably thinking, well, it's kind of intuitive. This list probably, if you gave me that list now, I could probably in turn address them with Peter, and it would probably work. But there's probably something else going on, because Peter's situation is not just a checklist of items or factors that we can then tick off by talking about it. I'm going to just give you this transcript from one of the reported incidences from Peter. So I'll read this to you. This happened probably about 10 minutes into a patient interview between Mr. M and Peter. So Mr. M says, "I told you that the pain is from the back of the knee." So Peter looks a bit puzzled. "Okay, and you said you have," Mr. M interrupts him and says, "patellofemoral pain syndrome." He looks starting to look frustrated. "Look, all I need are exercises." Peter says, "Yes, I'll be able to give you those exercises, but and he keeps looking from his assessment form to Mr. M's knee. Mr. M abruptly says to him, "Is your supervisor around?" And he's looking around the clinic for the supervisor, and Peter politely says, "She's with another patient right now, but she'll be back." Mr. M says, "So how long have you been doing this?" referring to his student status. So to me, just in this brief transcript of what happened during the clinical encounter is in part representing the three circles that I told you about, but there's a bit more to it. I think, and the author of some of these papers about context suggests that the contextual factors don't exist in isolation, but in actual fact, they interact with each other in very complex ways. In other words, Peter's ability to manage or respond to the patient factors, the encounter factors in real time, and are also important for us to consider. So one study, McBee is one of the researchers in looking at clinical context. McBee suggests that the clinical context is really this weaving together of all three of these bubbles, all the three groups of factors, the therapist, the patient, the encounter. And this weaving together may be represented in how these factors interact with each other and some of these narratives that I just presented to you. So this interaction between factors is something that researchers are just beginning to study. I think we've lived it. I'm sure that transcript is not foreign to you. But it's something that we've lived. So in this study, they actually examine the contextual factors and the interaction between them. And one of the key findings from this study is that the way they define context is in like this diagram. And that changes happen during the clinical encounter. That sounds pretty rudimentary, and I think we know that in the back of our minds. But being explicit with that is really important when we talk about context, which makes sense to me because we are continuously accumulating information throughout the patient encounter. So the patient is reacting to what we say, the patient's reacting to what we do, and vice versa. We are also reacting to them. All the while, we're trying to make sense of all this, the reactions. So the obvious sources of some of this information is from our patient interview, from our physical exam. But I think that feeds into the clinical reasoning process for sure. But I think it's also important for us to remember that relating to the patient, so some of the things that Mark talked about, relating to the patient and them to us, the words we use, the words we don't use, the words we leave out are also really important. That all influences the way we reason. So, although the diagrams in this figure here are representing the interactions, I think it doesn't quite do it justice. I think because it's still quite a static diagram, and it doesn't show the dynamic nature of clinical reasoning enough, that it evolves over time throughout the clinical the clinical encounter. So far, I hope I've convinced you that clinical reasoning is much more complex in these ways about the contextual factors. So what do we do with this information? What do we make of the contextual factors that we talked about? Well, I think to understand what we can do about it, we need to understand the underlying mechanisms. So here's some theory behind how it might work, and maybe understanding that will help us know what to do with it. So one way to explain these contextual factors and their effects is using Erikson's work on one's working memory. So we know that unlike long-term memory, our working memory is very limited. It has limited capacity for us to be reasoning in the moment. And so people use what we call chunking strategies, right? So we group things together so that we can store them in our long-term memory. It frees up space in our working memory so that we can do our reasoning process as we go along. And we know that experts are particularly good with this. They can do this easily. They can chunk information easily. They can store it into long-term memory. They can retrieve it effectively and efficiently. So this chunking strategy reduces what we call cognitive load. It frees up space in our cognition, our cognitive activity space, so that we can do with it what we want. So for example, clinical reasoning. Another way to put it is novice learners, such as Peter, who is working with who is trying to interpret the contextual factors, who's trying to deal with a lot more information and maybe not quite as good as chunking the information to store in long-term memory, has maybe less working memory to deal with clinical reasoning. The other thing to note is that not all contextual factors are equal. As I said before, one of the things that researchers have looked at is when they manipulated the contextual factors, that language proficiency was one of the greatest influences on clinical reasoning. In other words, if your patient isn't able to communicate well with you in the language that you're using, it's very difficult to then to reason through the problem. I think partly it's because of their ability to convey a certain message and your ability to understand or interpret it. So there's actually evidence to show that not all contextual factors are equal. As I said, language proficiency is probably one of the things that clouds clinical reasoning. And there's this thing about interactivity, and I want to just take a moment to talk a little bit about that. So recently, some researchers have played around with the different contextual factors and categorized them based on this idea of high interactivity and low interactivity. And I'll explain what that means. So information that has low interactivity can usually be processed and understood on its own without consideration of other pieces of information. So relatively speaking, they don't use up a lot of our working memory. So in contrast, information that has high interactivity usually demands us to consider other pieces of information, other contextual factors, to be able to be processed and fully understood so that we can interpret it. So information that has high interactivity uses up our working memory, uses up our capacity to reason in the moment. And when you pile on multiple factors, especially ones that have high interactivity, it really compromises our clinical reasoning. And that's the theory. So let's talk about the implications. So what? In other words, how can we help someone like Peter? What does all this matter? So I just want to reiterate that at the end of the day, my talk isn't really to downplay the importance of the individual's cognitive processing. That is critically important. The knowledge base, the processing ability is critical. But I don't think that's the only thing that we need to focus on, that we should be focusing on. So how many are practicing physiotherapists right here? Show of hands. Okay. How many are okay. Sorry, I forgot about the delay. How many are educators, teachers? So either formally or informally. Okay. And how many are researchers? Okay. Good. So this slide is about, I want to talk about the implications for your own practice. I think that probably has implications. I'm going to talk about practice, education, and research separately, but they obviously overlap. First, I think we need to develop ways, if you're practicing, to actually practice this. Practice managing our contextual factors, whether you're a novice learner or you're someone who's been practicing for a long time. I think particularly because of this idea of cognitive load and how it takes up space in our working memory. So in Peter's case, when we're dealt with a patient who has multiple contextual factors, we need to be practicing how we deal with that. And I think this applies to, again, novices and also experienced people. In my own work, what I do is, part of my work is I mentor physios working towards the diploma in orthopedic manual therapy. We often play this what-if game that I give them lots of different scenarios, and I start piling on the contextual factors to ask them, what if this happens? What if the patient reacts this way? What if the patient also does this or has this contextual factor? And I think, although it doesn't replace actual practice, authentic practice, seeing real patients, there's a real value in having them reflect on and trying to be very explicit about the contextual factors that are at play. Because often, as we saw in research, that can be missed, that can be taken for granted in the clinical picture, and it's not something that is natural for us to pay attention to. I also ask the physios that I mentor to jot down in a given week or time period specific times when they felt like they're struggling in their clinical reasoning. I think, as you get more experience, that probably happens less frequently, but it's probably still happens. And I think there's value in trying to notice the moments when you've either committed an error in your judgment or notice moments when you're struggling a bit. And not just to notice them, but then tag them to contextual factors that might be at play. So I think identifying them is really critical in our practice, and then so we can try and address them and mitigate them. So for those of you who are educators, either formally or informally, maybe you have a colleague of yours who is more junior and who asks you questions about their practice, or you supervise students. I think some of these points will apply to you. So if we know that each clinical encounter comes with its own unique combination of contextual factors, we need to ensure that our students are equipped with, our novice learners are equipped with, and capable of being flexible and tolerant of some of the ambiguous situations they might be coming up against. As you know, things come up in our clinical encounters that are not anticipated. We can't anticipate, especially through our preparation of knowledge and processing. It's not enough. I think we need to develop students who are more ambiguous, who can deal with ambiguity. In the work I do at the University of Toronto, I was just telling Roger and Mark over a meal last night that we're undergoing a big curriculum change and redesign, and one of the main focus of our redesign is to develop ways to try and push our students to be more flexible, to be able to deal with ambiguity in a more robust way. so that they're more resilient. And one of the applications of that is in these contextual factors, to be able to help them deal with the contextual factors better. So just like in practicing therapists, I think if we can try and cue our students to be able to think about and recognize contextual factors, it'll go a long way for them. So finally, if you're a researcher interested in studying clinical reasoning further, we've got lots of work to do. As a researcher, that's always good news that we have work to do and different questions to be able to investigate and explore. So if this is how context is defined, so if I pop the diagram back up here, if this is how the context is defined, that it's not just the therapist factors, not just about the patient, not just the encounter, and it also includes the interactions between all those bubbles, all those factors, then we really have to try and tease out what that context is in our own world, so in the physiotherapy world. And I say that because in my investigation of the literature, I see very, very few studies that dive deep into the context in the way that we've talked about here, especially in physio. And our context is uniquely different from medicine, from nursing, from pharmacy, from other disciplines. So we have a lot of work to try and carve out and try and define for ourselves what our context looks like and what those interactions look like. I think we also need to explore specifically how those interactions occur between these factors. So whether they work in concert with each other and the ways in which they compromise or limit our clinical reasoning process, especially in our non-experts. And when I talk about non-experts, I'm talking about those who are not just early to the profession or early to the learning about physiotherapy, but also the intermediates. So those of us who might be practicing, who've been practicing for 5, 6, 8, 10 years even. And I think because we're more susceptible, non-experts are more susceptible to some of that cognitive load I was talking about, I think we need to pay attention to that group in more detail. So I'm going to just loop back to the case of Peter as a way to conclude this talk. So what became of Peter? I think more importantly, the question is, how did we support Peter in developing his expertise in clinical reasoning, given what I just talked about? So with Peter, we definitely worked on his own cognitive processing, because as I said, without the actual processing, the knowledge base, there's nothing to discuss, no context to really discuss. And tomorrow I'll be giving a workshop on some of the strategies we use with Peter and helping him self-explain the links between his knowledge about biomechanics and anatomy, linking it to a real patient. With Peter, we also focused specifically on teaching him how to notice and account for the contextual factors in the clinical reasoning process. So definitely in paper cases, but more so as he moved on to seeing real patients and using some of the strategies I just talked about. And whenever possible, we try to model for him some of those self-monitoring strategies to notice and to work on the contextual factors. Fortunately, Peter went on to repeat his last clinical internship and was successful in passing that clinical internship. I think due in part to his growing ability to recognize and deal with, manage the contextual factors. He was placed in quite a busy clinic again, and a clinic where the patients were not very straightforward. So I think hopefully that success in passing that placement was due in part to some of the work he worked on to notice and manage the contextual factors. And finally, as I mentioned, at the university, we're redesigning our program, our curriculum, a huge overhaul. And this is one of the things that we're paying close attention to. And my hope is that in our curriculum redesign, we're equipping students to be able to manage these hosts of contextual factors better so that they can practice in settings that are more complex, as we're seeing patients in a more growing an environment that's growing in complexity. So with that, I thank you for your attention, and we'll pass the mic on to Roger.
Muchísimas gracias, profesor Yeung, por su ponencia. Y damos paso, sin prisa pero sin pausa, a Roger Kerry, Roger Kerry es fisioterapeuta, ha sido recientemente también ha conseguido el grado de doctor en fisioterapia. Él lleva bastantes años trabajando en la Universidad de Nottingham y bueno, uno de sus campos de expertía es lo que llamamos nosotros la evidence-based practice. Entonces yo creo que es prácticamente ahora mismo la persona ideal para intentar introducir o decirnos específicamente cuál puede ser el rol del razonamiento clínico en este tema. Así que cuando quieras.
Hola. So, I'm from Nottingham in the UK. The only thing you need to know about Nottingham, as you will remember, is in 1979 when Real Madrid got through to the second round of the European Championships and Nottingham Forest went on to win it. And then the next year he did a bit better, but Nottingham Forest still went on to win. And there ends the history of football, mis amigos. So thank you to Pablo and the committee and the organisation. Thank you all. It's great to be here. Thank you for inviting us. Thank you to the translators as well. And apologies to anybody who was at my talk yesterday at the University European Madrid, because it's very similar, but that's fine. We're going to look at this idea about the traditional idea of clinical reasoning and how that now works in an age of evidence-based practice. So since the origin of clinical reasoning, if you like, something has happened to the world, and I'm going to sort of position it, evidence-based medicine as this thing that came along after clinical reasoning began, and now we might need to think, okay, so how does that work? And just make some conclusions about a sort of updated idea of a clinical reasoning model. So a brief history of clinical reasoning, not that we really need it because we've had such fantastic talks all morning, we do know about this, but actually the history of clinical reasoning is sat right here in our room. I don't think anybody would argue that Mark has been the single most prominent figure in introducing these ideas of thinking about our practice almost single-handedly into the profession over the last few decades. So I wonder if we should just stand up and show our appreciation for Mark. And I do honestly believe, I think if it wasn't for Mark and his work and the teams he's worked with, we wouldn't be here today. We wouldn't be having a conference really trying to analyse this complex area. So it's a genuine appreciation. You'll be familiar with the classic textbooks, and just to note, as it was mentioned earlier, that the Clinical Reasoning Manual Therapist book should have a second edition in 2018, which again Mark and Darren Rivetta are the editors of, so very useful information. Of course, Mark didn't invent the idea of reasoning. That's part of the human condition, formally, I suppose, first spoke about with the ancient Greeks. And the clinical reasoning models that we use in physiotherapy are held up. The foundations of them are in the philosophical notion of logic. And what people like Mark have done is sort of bring those ideas into clinical practice and wonder how we make decisions. So one thing we should sort of remind ourselves of, I'm not going to do it now with you, but is those different forms of logic that we use and the limitations and the strengths of those. And we've seen some already, like the problems of induction and making predictions. And humans, to quote somebody, humans are really bad at making predictions, especially about the future. So this idea of thinking we know stuff and thinking that stuff will inform our next clinical decision is extremely challenging. And again, you know, just to sketch out this history, in the mid-90s, when the Manual Therapy Journal was first published, Mark was, I think this was, am I correct? This is the first journal. Yours was the first paper in the first edition of Manual Therapy, I think. Yeah. So a brand new journal comes into the world, and that you open it straight away. In the first page, there is Mark's paper on clinical reasoning and manual therapy. Now, I know this is, I know you can't really see that well. It's not a great copy of this model, but most of you will be familiar with this sort of clinical reasoning model that Mark and et al. Sort of developed during those early years. And we're going to come back to this at the end. And basically, this is sort of, if you wanted to talk in this in terms of logic, it's representing those different types of logic that were there. So we receive information, and then we make some sort of inductive patterns recognition and develop those hypotheses, then go on to test those hypotheses and make some decisions, and all the time that process is being informed by additional information from the patient's story in the physical examination. But not only that, it's more than a subjective history in a physical examination. It's incorporated more about the patient. So the patient column on the right there is really all about trying to get a deeper understanding of the patient's life that they live in. And again, Mark sketched out that psychosocial dimensions, which we've got a better vocabulary to talk with now than perhaps in the mid-90s or something. But all the ideas were there. But there are still critical times when, although this is a very flexible and nuanced model that develops over time and with unfolding information and so forth, there's still critical times when binary decisions have to be made, like what is the problem, the diagnosis, and then what are we going to do about it, the therapeutic intervention. So it's where does the tipping point come from with those decisions? What gives us the confidence to make that diagnostic and that therapeutic intervention decision? Now, what I want to do now is position a single person within this whole model, and that person is the expert, because we've seen again all morning examples of the transition from novice to intermediate to expert, and there's a suggestion that the expert practitioner is a better clinical reasoner. And it's been said again a few times that it's not just years of practice that make you an expert. It's not just experience that makes you an expert. It's something else, and one of those things is this ability to clinical reason. So the idealized clinical reasoning model is really perhaps sort of saying this is what an expert does. And if that's the case, then those critical decisions like diagnosis and therapeutic intervention come from the expert, and it's something about the expert that's driving that. And perhaps the expert has also got that background clinical knowledge to make predictions based on what they've seen before. So they've seen stuff work before, and they can integrate that into the decision-making model, and they make a prediction of what might work again in this case that looks very similar. And again, just examples of the early clinical reasoning forms that were published by Mark's University. And again, interestingly, right at the top of those forms were prompts to get the therapist to think about the psychosocial dimensions of the patient before the tissue pathomechanics were entered into. So I'm just putting these up as examples of how we might have prompted critical analysis and clinical reasoning in therapists at that time. And again, attention towards pain mechanisms, and we consider these now, but again, the terminology is slightly different and the data beyond its time of distance. But again, there's a suggestion here that when did you start this, Mark? Was it in the 80s, 70s, 60s? At that time, there's a suggestion that it's sort of that being too sloganistic, this was ahead of its time, because this is what pain neuroscience now is starting to support this idea of different pain mechanisms and the importance of centralization and such forth. So, back to this idea about the expert. So the expert sits in the middle of the idealized clinical reasoning problem, and he's the one who can make those decisions based on that clinical reasoning process and based on his own biomedical and clinical knowledge and other forms of knowledge as well. And he's very good at that. But then, something happens. Along comes some people from Canada, Gordon Guyat and his team, and they produce a paper in 1992 called Evidence-Based Medicine, a new approach to teaching the practice of medicine. 4 years later, Physiotherapy formally caught up with this and started producing its own publications called things like Evidence-Based Practice in Physiotherapy. So there's this critical time when seemingly the world starts to change. And explicitly, obviously don't read this, I'm characterizing it now. These are 2 paragraphs from that very paper. Explicitly, what Guyat et al. Say is that until this day in 1992, the world of healthcare behaved like this. From this day in 1992, the world of healthcare is going to behave like this. It's a new paradigm, a new way of teaching medical students, a new way of practice. Forget how we did it in 1991 and previous to that. This is now changed. The world's changed, okay? And if you don't buy into this, there's going to be some trouble. And that dialogue still exists today. The key difference, and I've highlighted paragraphs there, and I know it's difficult to read, but basically what it's saying is the former paradigm was invested around the expert and the good clinician and the good doctor and what they knew, and a loose reference to published literature. The new paradigm was all about reordering the priority there. The priority became systematic scientific research, and the role of the expert was de-emphasized to say the expert should not be given as much trust and value in clinical decision making as the scientific data. And then David Sackett followed this up a year later with a paper on what is and what isn't evidence-based practice, and sort of reinforced that idea, but did it in a slightly subtler way, and he came up with that idea about use the best of the evidence, the best of the patient, the best of the clinicians, but they didn't really believe that. If you look at the subtext of those papers, it was all about use the best of the scientific research, don't really bring these other things into it. So there's this real sea change, which then, if we took that literally, sort of questions the role of the expert and therefore the idea of clinical reasoning in healthcare decision making. So we've got this el conflicto, perhaps between the old way, which could be characterized by the clinical reasoning module, and the new way, which could be characterized by access to scientific data, and then therefore, what is the role of the expert? Well, one extreme view of the role of the expert, which is quite explicit from the evidence-based medicine movement, is that the expert is now not somebody who's had years of good clinical experience and good clinical successes and can teach somebody something and can make good clinical decisions. So when you're ill, you would go to the expert to see them to directly use their logic and reasoning and experience to help you. An extreme view is that a medical expert is now somebody who can quickly access scientific data from population studies and has got the ability to translate that data into statistical phenomena like risk ratio, odd ratio, numbers needed to treat, likelihood ratios, and then can make a statistical commentary on your health condition. So that's at one extreme. So at one extreme, there's still holding on to the old expertise, clinical reasoning thing. At the other extreme is the idea of a healthcare practitioner expert is somebody who can access databases quickly. But I'm just wondering if there's something in between that, and that actually we can reach a point of la réconciliation. La réconciliation. I've been practicing that for like 2 days. And I still can't do that thing. Come back next year. So let's just step back and revisit the world, the world which we could say is actually, despite the best efforts of the evidence-based medicine movement, is complex, and it does involve context-sensitive behaviours. So each individual situation is different because of that situation, and obviously that's just been fluently sketched out by Euson, so we don't need to go into that, but just stepping back, look at all these, and this is just a selection of components of the complex world of healthcare at any one time. So at the top there we've got the illness narrative that we know about, the patient's story, but not just the history taking, the real understanding of the patient's life, and going anti-clockwise, those psychosocial contexts that Mark's been talking about, our sort of tacit acquired knowledge that also involves all sorts of heuristics and shortcuts to accessing different types of skills and knowledge and making decisions. Objective examination findings, but again, not just in a sense of this is a positive test, but it's more about the understanding that human and how they're interacting with the world. Explicit knowledge from a variety of sources, and then we do have scientific evidence. So in a complex world, scientific evidence might just be one part of the complex world. And a science extremist might say, well, actually, that scientific bit there that you've just got as one bit sort of encompasses of all that other stuff. We can make scientific commentary on all that. And that's probably true at a population level to a degree. But as we keep hearing all day so far, there are differences in each individual situation which we need to account for as well. So here's a quick case study, and I'm using this case study for two reasons. One, because I'm familiar with it, and two, because it's also published by Matthew Lowe, and I've put the reference down there, so if you want to go and read more about the sort of underpinning thoughts and reasoning for this, you can do, but I'm just going to briefly go through it. So Jack was a simple young chap who was referred to a musculoskeletal outpatient department with back and neck pain. That's what it was, and he'd already had a couple of episodes of physiotherapy where they'd done some mobilization to his back, given him some advice and exercises, and now he's 2 and a bit years down the line, and his pain's getting worse, and he's been referred back to an outpatient department for more mobilization and some exercise and to get him going. So it seems a fairly simple musculoskeletal problem, but the point of this is as a seemingly simple musculoskeletal problem can be a complex context sensitivity situation, the sort of which neither clinical reasoning alone or scientific evidence alone can address. So I wonder if bringing those things together we can understand somebody like Jack more. Now, again, this is a mind map that was produced in collaboration with Jack. So Jack helped fill these thoughts out, and there's some so we're picking up on the psychosocial aspects of his the story that he gave in the subjective history taking, and we're relating that to a background evidence base that's from which we can understand the positive and negative prognostic predictors from the psychological and social dimensions, and all the time trying to have this discussion with him about how that relates to his painful experience. So his neck and back pain isn't just because there's a stiff C3, 4, 5 facet joint on the right. It's a little bit more complex with that. And then we sit down with Jack and we fill in what we call a vector diagram, which is basically trying to identify all of the components of his biological, psychological and social story the way his life is at the moment, how he feels, which parts of that are tending towards making things worse and which parts are tending towards making things better. Then we can superimpose the population data on top of that and say something like, well, you know, actually physical activity and non-specific exercise is a good thing for this sort of painful condition. So we want you to do that. Now, if we were just practicing evidence-based healthcare, what we would say is, okay, Jack, you're somebody with chronic spinal pain. Physical activity is good for you, so do some physical activity, okay? But we know from Jack's story that he's got fears and anxieties about movement, and actually every time he tries to do some physical activity, he's so worried because of what previous physiotherapists have told him about his pain that he fears is going to make it worse. So we can't just do evidence-based practice. We can't just say, here's a high-quality systematic review and meta-analyses of high-quality randomized controlled trials, and they all say that exercise and physical activity is good for people like you. We can't just do that because there's other things manifest throughout his story that will actually, rather than make things better, make it worse. So the arrow going to the right there for physical activity is an evidence-based arrow. We know there's the potential there, but we can't do there until we address something like his stress and his fear, and particularly his sleep hygiene and anxieties about movements and beliefs about his health condition. He believes that he's going to crumble away because the physiotherapist told him there's wear and tear in his joints and he's unstable, so his head's going to fall off and all of those things. So we can't do evidence-based practice until we've really engaged with his deep life story. And of course there's things that come from his story that are non-modifiable or would be difficult to modify, like his mood and depression and his social support. But as Mark said, you know, things like social support are really strong sociological background conditions that would either limit or help pain experiences. And of course there's nothing we can do about his previous experiences. That is in his time building up to the onset of the pain, his time during the painful experience. We can't do anything about that, but what we can do is is help him work and change his beliefs about those experiences and reconceptualize and reposition that. So this is just another way of saying the nature of expertise rather, not experience. The nature of expertise before the onset of evidence-based practice was basically probably somebody who was good at the clinical reasoning process, but was also the sort of sole point to recommend what either diagnostic or therapeutic intervention should be given. And EBM downplayed that. Now, so here's the point of this. I think what EBM says about the expert is partially right. I think there's parts of expertise that we should sort of abandon, and I think one of those things is the idea of making generalizable claims about what works. So whereas an expert in the past would have said, well, I've seen this work a lot, and this manual therapy will help again for this person with low back pain. I think EBM is quite right in saying that generalizable claims about therapeutic effectiveness is better done by well-organized, systematic, objective scientific research. And I think good randomized controlled trials could probably offer us something above what an expert could have offered about that. But that would also change in every context as well. But I think that's only about 2% of what expertise is. So when EBM says we de-emphasize expertise and clinical experience, I think they're just saying we'll de-emphasize this 2% of what expertise is. The other 98% is in fact even more important, because the other 98%, so we're changing the colour of expertise, we're changing it from somebody who used to go around saying, I've seen it all, I know what works, do this for this patient. We're changing it to somebody who is quite able to engage in a meaningful narrative with a patient, to understand their life story, to understand the complexities of healthcare generally and the context sensitivity of this particular interaction and relationship, and also able to draw in the relevant evidence and make that meaningful and contextualize population data within this particular context. So the role of the expert has subtly changed. Not that they didn't do that before, but there's more explicit parts of that, like the drawing of population data, that actually, rather than a de-emphasized role of expertise, the expertise needs to be even better and more exaggerated to do things like quickly calculate odd ratios or whatever. So we need, paradoxically, we need expertise to actually interpret the very evidence which is supposed to de-emphasize expertise. And there was a really nice paper written on this a couple of years ago, and I'm desperately trying to think the name of the authors, but they present the paradox of expertise, and I can't think of the names of the authors, so rather I'll direct you to my last paper last month in the Manual Therapy Journal, because I summarised what the expert paradox was, so have a look at that instead. And it's not even called Manual Therapy anymore. What's it called? Musculoskeletal Science and Practice Journal, the masterclass last month, so have a look at that. So I think rather than, evidence-based medicine being something that says, no, the old days of expertise and clinical experience is no good anymore, forget all that logic, forget that reasoning, which it sort of wants to do. It's saying, no, actually, we can be friends and we can work together, and actually you need us, you need experts to interpret your evidence that you're generating. So the early model of clinical reasoning that Mark's sort of flowchart earlier, this is just another representation of it, I think that's still absolutely as it is. We still generate hypotheses, we should still test those hypotheses, let our ideas unfold. The difference is we've got different sources of information which we can bring into that. So we've got diagnostic utility data, we've got therapeutic intervention data, we've got data that lets us know about psychosocial predictors of chronicity and all sorts of things, and we can just pump all that into our clinical reasoning machinery and work collaborative with the patient to make sure we're controlling for our own biases and make a better understanding of that particular clinical situation. So there's, I'm not saying that this is the new thing at all, but I've just been doing some work with Matthew Lowe and Peter O'Sullivan trying to put this into some ideas. So we've got a sort of tool that we're trying at Nottingham at the moment, which is, again, it's not rocket science. We call it something like an evidence-based multi-dimensional clinical reasoning framework, and that's just meaning, again, it's a different way of saying what's been said lots of times already. So 4 dimensions, which we know about: movement dimension, psychological, social and neurological dimensions, which has been presented before anyway, right from the start of clinical reasoning, but we mean different things by them. So movement, we don't mean something like, oh, move your arm and let me see how much you can use it and let me see if that's different from some tentative norm. Movement is about observing movement and looking for clues for apprehension and fear of movement and beliefs about their movement and appreciating the limitations of diagnostic tests and such forth, and wondering whether there's a load component and it's a force tolerance issue, or whether there's a movement impairment or a motor control strategy issue, and looking at those, again, things that are more informed by the evidence than sort of old school, does this hurt? Well, it's therefore it's that. Same with the psychological, positive and negative predictors of prognosis. Same with the social, what's the sleep hygiene like? What's your work situation like? What's social support like? And neurological factors, looking at pain mechanisms and the role of sensitized brain. And then the role of the expert is to not have a framework where you've got 4 dimensions with white space between them, because that's just another reductionist way of trying to work out a complex situation. So if we wanted to be truly holistic and evidence-informed, the role of the expert is to sort of listen and work with the patient to bring all these dimensions together, so you get a completely unique situation that cannot, because there's so many variables in all of those dimensions, the chances are it could never be the same as another person. So we start to think of each patient is an individual patient. They're not just a component part of a population study that we can directly bring population down to. There are so many other variables that need to be considered, and the framework to consider those variables is one of clinical reasoning. So there is no evidence-based framework as such that could do that job for us. We still need that clinical reasoning framework. So although statistics do matter, they're absolutely important to our understanding of the world of healthcare and population health, they don't quite get me. Gracias.
Bueno, muchísimas gracias al profesor Roger Kerry por su ponencia. Estamos bastante fuera de tiempo. Quería recordaros que mañana por la mañana tenemos 2 talleres en los cuales Euson y Mark os harán una demostración práctica de lo que han traído aquí, ¿de acuerdo? Por lo cual les tendremos también muy cerquita para hacerles preguntas, ¿de acuerdo? Luego tenemos que empezar a 1:30 sí o sí, porque tenemos una tarde repleta de ponencias y una tarde que acaba un pelín tarde, que acaba a las 8, por lo cual tenemos que ajustarnos luego más tarde al temario. Pero no quería dejar pasar la oportunidad de que hagan ustedes algunas preguntas, por favor. Así que aquellos que quieren hacer alguna pregunta, que levanten la mano, por favor, y nuestro compañera se acerca.
Hola, gracias a todos por las exposiciones, han sido muy interesantes. Me gustaría preguntarles si con todos los pacientes hacen cuestionarios biopsicosociales y tienen en cuenta el contexto preguntándoles en la primera sesión, porque personalmente espero... tanteo un poco las perspectivas de los pacientes y en función de eso voy introduciendo esos aspectos a medida que voy teniendo confianza y les veo abiertos a estos temas. Gracias.
I would take a biopsychosocial approach from the first appointment, and I would begin to screen the context of the patient in my opening question. So obviously the patient starts by telling you what they've come to you for, but I then almost always will say, thank you. I'm going to ask you a lot of questions about that in a moment, but before I do, would you tell me a bit about yourself? Now, if they want to know what do I want to know about them, I then have a series of questions. But I always get a context before I go on to find out about their body chart or behavior or history. And it only takes me 3 to 5 minutes, and I don't feel I know a person in 3 minutes, but I feel I get a snapshot of the person before I start to find out about their problem. And I will use that to help me sort of decide on the priorities that I'm going to follow through the rest of my examination.
Ok, ¿alguna otra pregunta, por favor? ¿No? Ok, Ok, bueno, pues nada más. Me gustaría darles las gracias a los tres por haber venido desde tan lejos hasta aquí. ¿De acuerdo? Para mí es un honor haber estado moderando esta mesa con, bueno, pues con tres amigos y bueno, pues espero que haya conseguido llegar o llenar sus expectativas, ¿vale? Nos vemos esta tarde a las 3:30. Muchas gracias.